And yeah, welcome to today's session. You have a nice, lovely weather, Carlos. It's good to see you.
Yeah, always nice weather
Yeah,
in
lovely.
Spain.
Excellent. So I just need to have one headset off a little bit because I have two sick kids at home and I need to listen if they start shouting or screaming or something. So just bear with me in case I have to go. And so what I want to do today, first I want to ask you if you have any specific questions for me. Otherwise I would go through a few cases. No? Yeah.
Nothing really specific.
Okay,
Yeah.
so then let me share my screen and we can jump right in. Okay, so amazing. And we go here. So I'm just going to go through a couple of these cases here that I have to answer anyway. So let me just see one that I didn't do yet. And let's see. Just go with this one. Dan has 3 cases. Oh, he just uploaded single images, so it just that's maybe a bit too complex. I want to take a case with some images, so let's go here. Okay, you can see my screen, right? Okay,
Yep.
great. So basically, Ritish has a question about pesanthera and bursitis versus ganglion cyst. We have the case. Let me just preload the case. So, and the question is, does it look like pes enterine bursitis, maybe chronic, or more like a ganglion cyst along the pes enterine tendons, and how to differentiate? What about the cysts seen posteriorly? Can I label them as posterior capsular ganglion cysts, or are they PCL ganglion cysts? And then medial meniscus looks like a grade 2 change in the body posterior horn. Why is there impression of extrusion on coronal images? Okay, let's start with the meniscus. It's quite a frequent question when we see a little bit of extrusion. It doesn't always have to be associated with a radial tear or a root tear, although the root here looks a bit funny on the coronal. So we want to make sure we understand the signal of the root on the axial and also on the sagittal plane here. But there is a bit of extrusion. We see some mild internal signal changes here at the body. Also the meniscus in general looks a bit degenerated. It goes all the way also here to the posteromedial aspect. And then the root here, it looks a bit high in signal. So I want to verify this on a sagittal, as we can sometimes fall in partial volume problems here. And I like the sagittal quite a bit for this. So we see the anterior horn, the root, also a little bit of higher signal, a bit of degeneration here. So we go over here, follow it, posterior horn. Body, we cannot really say much on a sagittal. So we go here, here, here. This, the edge here looks a bit truncated, especially then on this image here. It's a bit of a sharp line. We can actually check on the axial later. So I want to follow the thing here, and I think it becomes quite bright here. I don't see a complete tear, at least. Let's see if we have any other sequences which can give us a bit better understanding about this. Again, we have this truncation of the tip of the posterior horn of the medial meniscus here. Going back here, it looks a bit more black, so we don't really see a fluid or a ghost meniscus or anything. So I'm thinking more now currently still with degeneration and fraying of the root rather than a tear. Just gonna window this a little bit less aggressive, and I want to see this also on the axial now, where we can see these irregularities first of all here in the tip of the posterior horn. This is the area where we had, let me just go to the, it's not correlated, but this area here, this irregularity is here, the truncation. So we've got a little bit of a tear, a radial tear, and fraying of the tip of the, or the free edge of the posterior horn of the medial meniscus. You can see the nice smooth border here. Here it's still okay because it's fading out with partial volume, but here the sharp change in contrast means it's not nicely fading out. So that's corresponding here to this truncation that we have here. From here to here, there's a little radial tear. This one might even be a tiny bit of a flap floating around here in front of the tip. We can't really see this any better in this resolution. So in terms of the root, I don't see a separation here on the axial. I think this image might be already too high. We can see this is already the bone of the femur condyle. So you know, when I look here, this would be more on this level. So I think this is above certainly this level. So we see a lot of this high edema tissue here in the pericruciate fat bed anterior to the PCL, and the root would be a bit more deeper, so it's somewhere in this level here, just going in front of the PCL or close to it. So we see the PCL here. So this would be the area of the root. So I would be going with some degeneration and fraying. There can still be some small micro tears that we cannot really appreciate now on these images. Just gonna see if we missed any of the other images. We have a 3D. Okay, let's have a look at this. But the resolution is not so great. It's just the same thing. We can see the signal changing from nice and black, going down a bit here, increasing a little bit. So yeah, we got a little bit of degeneration and fraying of the root, and that can already take out a little bit of the tension of the ring tension of the meniscus and lead to some degeneration just based on the stretching. And I think there are these two concurrent or opposing theories. What's first? Is extrusion first and then the root tear, or is there first the root tear and then the extrusion? I think it can go both ways. So wear and tear, degeneration, posterior root, middle meniscus with extrusion. And if this obviously then progresses, this can lead to a complete root tear eventually. So that was one question. The other question was ganglion cyst posteriorly behind the PCL and then also at the pes anserine bursa level. So let's go to the posterior first. Here we see these cystic changes. It's a bit too bright. Just need to window this a bit different. Yeah, we can see this ganglion cyst here. We can see part of the joint capsule actually here. This is part of the joint capsule here. PCL is this one. And we can see that some of these components are inside the joint capsule. Some of them are actually outside of the joint capsule. I would call this a capsular or posterior or popliteal capsular ganglion cyst. I don't think I would go or associated this with the PCL, although the PCL itself also looks abnormal, but I don't see a distinct origin of these ganglion cysts, and I typically don't really try to find them. The question is, does it arrange out of the root? That's possible. We can see these changes here. There's somewhat, I kind of like imagine there could be a tiny neck into this degenerated root here as an indication there might be a little tear inside this frayed and degenerated posterior root. So I think that's what I probably would go with since the proximity is there, and I seem to think that there is a bright connection there. Let me just see this on a different plane. So this is this meniscus here. It's just sitting anterior to the root. This is not helpful, so let's go to the 3D or this one. Here on this one, we don't really see a proper neck. So I think the question is it a part of a ganglion cyst of the meniscus, or is it just a capsular ganglion cyst? I don't think it matters. We've described already some changes here. I think capsular ganglion cyst would be okay, and also a or popliteal or capsular ganglion cyst or a posterior root meniscal, parameniscal ganglion cyst. I think I would be okay with both, but most likely just a capsular ganglion cyst that we can occasionally see at this location. Yeah, so then let's go to the pes anserine tendons. Here it becomes a bit busy. So we can see the three tendons, semitendinosus, gracilis, sartorius, gracilis, and semitendinosus coming down. We see some of these fluid collections here. This is where we would have the Baker cyst. This one seems to be more around the semimembranosus tendon going down underneath it here. And I think this is quite deep. So it's not just underneath the pes anserine tendons, it's more posterior to it here. It goes between the muscles, medial gastrocnemius muscle and the distal semimembranosus insertion here. And again, this looks a little bit more like a ganglion cyst, so we're just going to go through the different planes and try to understand what it looks like, or whether we want to go with pes anserine bursitis. So the 3D. I think the polylobulated aspect and part of it, which looks similar, go also up here around the semimembranosus tendon. I think I would probably go with a kind of like a microlobulated large ganglion cyst complex rather than a distinct bursitis. It's not just like one nice collection. I think there are some septations in there, especially on the 3D. It appears to be a microlobulated cyst. We've got some interdisposed fat. Differential wise, a venous malformation would be in the game, but I think for that I kind of like collect the tubular structure, and it's interesting that we have this trace of fluid here all the way here to the tibial nerve. I don't see an obvious connection between these components and this one here, But I think I would just go with a large ganglion cyst at this point rather than with a proper bursitis, because I think it's a bit too diffuse. It has this connection up here where we sometimes see ganglions arising from a Baker cyst into different locations here. Because it's only here at this location, there is also a semimembranosus bursa which is distinct from the Baker cyst. That's another thing we can think about. But the neck here going down, so I would just go with a ganglion cyst around the semimembranosus tendon insertion here and call it that, and that's it, I think. Yeah, I think that would be the 3 questions. Do we have any questions from the people in the call about this case? Why not Baker cyst? Okay, so the first question, ganglion or synovial cyst. So basically not really sure the difference. Like, I don't use the term synovial cyst except for facet joints in the lumbar spine, where we have a synovial lining, whereas in ganglion cyst we don't have a proper synovial lining. On imaging, the distinction is not so clear because we don't really see this lining. It's more like on a histological level, this differentiation. So I'll typically go with ganglion cysts. I don't think it's important to separate. And why not the Baker cyst? It's just the location. I think the Baker cyst doesn't, if it's this big down here, and it's not really just one camera or like one loculated component, it's more like this diffuse thing. It also doesn't look like hematoma or a ruptured Baker cyst or anything like that. And the true Baker cyst would be here between the medial head of the gastrocnemius and the semimembranosus. So this was where we have the true Baker cyst. And if we just have fluid here, it's something called the semimembranosus. There are some small, lesser known bursae around which people sometimes separate from the Baker cyst. Let's see if we can find a good illustration for this. Yeah, you can see this is a similar location here. The semimembranosus or tibial collateral ligament bursa, they sometimes give like these 2 things, and it should be differentiated from pes enserine bursitis, which is more anterior and more distal. This is, in our case now, obviously this is a bit more distal and a bit more anterior, but it has also this second component up here. And the question is, are these now 3 separate entities, one here, and here? Well, I think it's just one thing that just grows down there. And I don't think this is really an important distinction, and I would not really try too hard to separate it. So I would just go with a ganglion cyst, and I would, given the appearance, I would not even use the term semimembranosus tibial collateral ligament bursa here in this case, because it's not just like a proper collection. For me, it looks more like a ganglion cyst. Okay, that's good. So I'm gonna answer this. Posterior horn, middle meniscus fraying and degeneration with extrusion. Extrusion, radial tear, posterior horn. Posterior, this would be posterior root. And then posterior capsular ganglion cyst, most likely. And the last one was diffuse microlobular ganglion. In my view, not pes enserine bursitis. I think pes enserine bursitis is not so common. It's maybe more like a clinical term. Okay, so good. Yes, Iman has a case. Great, so we can go through that one. You have a case. There is, so let me just preload the case. And your question is there FPL tenosynovitis? I am confused about the contrast uptake in the articulation. Okay, and there's a 57-year-old with query for Decker-Watt tenosynovitis. Okay, so the French always have things upside down for some reason. Is this the same in Spain, Carlos?
Yeah. I don't know why, but I think it's something about the, I don't know, the providers that they.
Okay, so let me just get oriented. We got a T1, which is not super important. We got a PD with a lot of fat saturation issues, the sagittal space. This is the space, okay, and then there's some contrast study. Also, we want to have this one. No, this is still proton. This is post-contrast, okay. Oh, not good. They tried again, better, okay. Yes, okay, so we can use this one is a PDT1. And your specific question is FBL tenosynovitis, okay. So yes, we can see there is enhancement in fluid here also, mainly along the flexor pollicis longus tendon here. I mean, this is tenosynovitis. There's not much in terms of differential. We also see other areas of synovitis, midcarpal, radiocarpal. We see also a bit of synovitis in the distal radio-ulnar joint. We see quite a stark thinning of the disc here with a cyst and also cartilage loss adjacent here in the lunate, in the proximal lunate facet. We don't see much degeneration of the ulna head itself, but this could indicate either a mechanical issue in the sense of an ulnar impaction, or it's just like synovitis related or something. But I think there's a mechanical component to the whole thing. Then we have the edema here in the trapezium. This is the post-contrast with enhancement. There seems to be also a cyst here adjacent to it. So we've got some interosseous or subcortical cyst also. And the other tendons, flexor carpi radialis, has a little bit of fluid here. This is less obvious. It's only one partial ring here. It's not very obvious, and I don't see, well, just on one image, a bit of very faint enhancement here. So a little bit of tenosynovitis there. We've got a bifid median nerve with a small persistent vessel here as just an anatomic variant. Then again, we see this in the post-contrast series, quite a lot of synovitis in these different joints. So we also want to make sure we see the extensor tendons, where we can see a little bit of fluid in the fourth and the second extensor compartment. And the post-contrast study doesn't really show too much. It's a bit very faint here. I would probably call it, especially in the fourth extensor compartment, even if it's very subtle, but I think we cannot just forego that. And also we have a very mild tenosynovitis of the extensor, of the first extensor compartment, where they suspected the Gervais tenosynovitis. EPL, or at the proximal intersection here, we don't see specifically an irritation of the first extensor compartment. EPL comes over distal intersection. I don't see separate, like a focal inflammation there, which would indicate a mechanical issue. So yeah, so we've got tenosynovitis at different locations. We've got synovitis. We've got some additional degenerative change potentially from a mechanical conflict, but this is suspicious for an inflammatory background disease like rheumatoid arthritis, or any other form of these diseases, especially because we have also tenosynovitis. If you just have synovitis and we have these changes here, chronic mechanical impactions can lead to synovitis. Also instability can lead to synovitis, but here this is more like the extensor and especially the flexor tenosynovitis is not explained by a conflict between ulna and the proximal carpal row. So that's where we have to think about rheumatoid arthritis, and I would also mention this in my report that we have these locations with synovitis, tenosynovitis, and is suspicious of a inflammatory chronic inflammatory disease like rheumatoid arthritis. And I would, depending on the referring physician, I would actually recommend a rheumatologic a follow-up, especially if it's not from a rheumatologist. Obviously, if it's from a rheumatologist, then he will already know what to do. But if it's from a GP referral, I would make him aware that he should probably have a look at, or refer the patient to a rheumatologist to get a better understanding. You can also see the flexor or FPL tenosynovitis here. Some additional muscle slip. This is just a muscle slip that goes in here. But yeah, tenosynovitis, FPL, like you said, Ivan. Okay, so then let's go here. Let's just pick another case. So we did this one, massive tear, I think we covered this, shoulder. So let's go here to Ryan's case and open this. Okay, so it's loading. Let's have a look at the question. Ryan is asking 27-year-old recurrent shoulder dislocation over 10 times, mostly during sleep. Interesting. There's a soft tissue bankered until sex lesion. And then what is the structure point with arrow below? Okay, so we've got two images, torn MJHL and coracohumeral ligament. SJHL, can't see. Is there a SLEP 2? Okay, so there were some arrows. So one arrow was this one here. And the other one was pointing here to this structure. By the looks of it, this was an arthrogram. And so this thing here, that could be bubbles, air bubbles or gas bubbles. On the T1, we can see they injected a little bit of air. This can happen sometimes. I think the registration is not perfect with the 3D cursor, but when we come down up, let me just window this a bit different. So we come up here. This is this pocket of bubbles, which we cannot really appreciate as nicely as it is here, but this is basically longer of the biceps tendon. There's one gas bubble, and then middle of it is another one. And this would be, one is this one, and the other one is this one. So it's in from the arthrogram, some injected air bubbles. We can also see them here, and they typically are at the anti-gravitational direction. So if we have the axial, this is the only axial we got. So you would expect them at the very top of it anyways, because air or gas is going against the fluid upwards. So these are two gas bubbles. The other structure would be this one here. It's this one here. Now it's not the MJHL. This is too high. I want to verify this now on a sagittal, which is a good sequence for the MJHL. So we can use these two. The MJHL typically on a sagittal, we can see here, we can see severe glenoid bone loss, chronic shoulder instability, but the MJHL typically comes down somewhat like this, blends into the back surface of the subscapularis. We can't see it here. No, it looks chronically torn. And these structures here are somewhere here at the roof. And they are sometimes, so this depends on which name you want to use. Some people, you can see literature where they point the arrow on this structure here and they call it the SJHL. But then again, some people use the SJHL for these more like in this orientation together with the coracohumeral ligament and then forming the pulley sling. And there is an article that has a different name for this. I forgot the exact name. It's some form like the, I think the coracoglenoid ligament or something like this. Coracoglenoid ligament. This one. So you can see this is the kind of like an axial view, and the SJHL goes over to the lateral side together with the coracohumeral ligament. They will form the pulley sling, and then the one that goes kind of like between glenoid and coracoid process, they termed this in this particular article the coracoglenoid ligament. But this is let me see if they have some MRI images for us as well, maybe some good ones. But this is not the only article. There is different articles that show the same thing. Let's just go to ligaments. Just to find, let's put MRI, because that's how we find it. Yeah, coracohumeral ligament. So you can see here this arrow, or this, yeah, that's the proper article, because they also have, first of all, it's a better reference skeletal radiology, and they have also some cadaver correlation. So coracoglenoid ligament, just gonna, where is it here? So you can see, and there is a variation, and most people, we have these two ligaments and the longer of the biceps tendon. This is SJHL, coracohumeral ligament, and then they have these different variants where you have the coracoglenoid ligament as a variant. And you can see this is the structure that, you know, when we go back to the case, just gonna make it nice like this. And so this structure here would be part of the coracoglenoid ligament if we want to actually give it a term. And the SJHL I typically only really look at the SHL as part of the biceps pulley, the sling that comes here down. It's not very nicely seen. This is, I think, it's the air again. So the resolution doesn't really give me much chance to see the SHL, which would come down here. Okay, yeah, so that's that. And then there are different, I think in this article also different thicknesses of these ligaments. They can, you can see here, they can be broad, they can be thick, they can blend in together, they can have different sizes and so on. So there's a lot of variation. I don't think it's clinically a very important structure. So, and then the last question was, is there a SLAP 2? So let's see that. So we go here, biceps tendon. This is the biceps tendon, it comes in. Here at this level, we can see there is some mild degeneration of the biceps anchor itself. At this level here, there's no contrast going in. And this one here is still, based on the orientation, some signal change that doesn't really go into the substance itself. So we have a little bit of undercutting here. Part of it will be cartilage. So I would not give a SLAP 2 here, but I'm not a big SLAP caller in general. So I would just go with a bit of degeneration of the labrum. Let me double check the age. 27. So he's still in an age where technically I would call a SLAP tear. But I think in a case like this, with this severe instability, this is not a main concern. And I would just go with a bit of degeneration. And here, this is partly a little bit of undercutting of cartilage and adjacent labrum degeneration, but I wouldn't give a distinct SLAP tear. Also here, it's not looking super wide by any means. Here, and the supra-posterior aspect here, I don't see a tear either. The signal here often is a bit brighter, just based on also a little bit of magic angle. They use the posterior approach for the arthrogram, likely ultrasound guidance into the Hill-Sachs defect, and then there was some loose body down here from, well, this is just like an old one here, but I think the main issue is the severe anterior glenoid bone loss in this case, which we can nicely see on the sagittal here with this big straight line. And what am I doing? And the loss of the circle, or best fit circle rather. Maybe put this on here. You can see there's quite a substantial piece missing. Okay, so let me just answer this. First arrow image gas from arthrography. Second image coracoglenoid ligament. Just gonna copy this article in here. See here. And no SLAP 2, I would say degeneration, fraying, if anything, SLAP 1, which would be per definition SLAP 1, but it's not a category that I personally use. I just want to show you one last thing before we finish up. SHL MRI. And you can see that the literature sometimes uses different terminology for different structure, which is super weird and makes our life unnecessary difficult. I mean, RadSource is like one of my favorite resources, but I think they got it. I don't want to say wrong, but they use the here arrow superior glenohumeral ligament. So they show this as the superior glenohumeral ligament, which for me doesn't make sense because it should form the pulley up there. So, and I don't see a connection over there. So that's why I would call the coracoglenoid CGL ligament here as another structure. Okay, and this is not the only article. There are many like published peer-reviewed articles that do the same thing, and you can just go SHL and you can find many of these things all over the place. Okay, so do we have any questions here?
I have a question that just came up, but I don't have a case to support it, but maybe just in theory you can answer, Chris. The other day we had a disagreement, a colleague and I, because she called osteomyelitis in a patient which the T1 was like just slightly grayish, not really black, not but it they did administer contrast, so it did enhance a little bit. But for me, the signal in the T1 was really not that dark at all. So in those cases where it enhances, would you still call it osteomyelitis, even if the T1 is just a little bit gray, not dark at all?
No, I think so. For me, I use the muscle as a reference, internal reference for me. The marrow should be, to call osteomyelitis, the same as muscle or lower. And we often see foci of osteomyelitis where we can see the dark marrow in T1, which is osteomyelitis, and then we still see the edema go beyond that focus. And everywhere where you see edema, you will have enhancement. So the enhancement alone will not prove that this is actually osteomyelitis. Reactive edema will also enhance. There will be kind of like a zone of transition. It's not like just like a sharp line. So, obviously there can be some form of progression, but if the muscle or if the T1 signal is not same as muscle or below, I would not call osteomyelitis. This is a very strict rule I follow. And the rest, when I see edema go beyond that, I just call it reactive marrow edema or bone marrow edema. Was the patient having having risk factors for osteomyelitis like ulcer and?
Yeah, I mean, she had it was like in the first metatarsal head, and she had an ulcer next to it. So I've seen people call it like not really T1 MRI definitive, but possible because due to the other factors.
So I mean, at some point it has to start, right? And I think sometimes it's just affecting the cortical bone or the very subcortical region, but not really all the way into the marrow. And I think then it's not really osteomyelitis, because that would imply it's actually the bone marrow which is affected as well. So it can just be like osteitis, or like something like this, or then cortical infection or beginning osteomyelitis or something like this. But I would stick with the T1 rule because it's simple to apply, and I think it has proven quite reliable for me. And the contrast alone is not reliable.
Okay. So we ended up performing a biopsy, so we'll see.
Yeah. How long was the delay between the biopsy and the actual MRI? Because that might also alter the result.
Oh yeah, that might also, I think it was like 2 weeks, a month.
So maybe if there was no treatment, there might still be osteomyelitis, and they will think you're wrong. But it's much easier to to be on the severe side rather than being on the good side. So this is kind of like being more sensitive. I feel sometimes is easier. It's sometimes more difficult to call. It's actually not the infection rather than it is infection.
Yeah, I try to just stick to the T1 marrow muscle. Yeah. Okay. Thank you very much.
Okay, so guys, that's it. I gotta go. It was just a short session today. I need to go to bed.
Okay.
Two sick children upstairs, so I gotta go and check on them. Yeah, thanks guys. I'll see you next month. All right, take care. Bye bye.
Yeah, bye bye.